Hello and welcome. I am so delighted that you are joining me for today's exploration of a topic that sits right at the crossroads of biology, chemistry, medicine, and even a bit of history: cholinomimetic drugs. Now, before you let that big word scare you off, I promise this journey is going to be simpler, warmer, and much more fascinating than you might expect. Cholinomimetic drugs are agents that imitate or boost the effects of a tiny but mighty molecule inside us: acetylcholine. This little chemical can be thought of as one of the body's most versatile messengers, sending out signals that affect everything from how your eyes adjust to light, to how your heart beats, to how you remember where you left your keys. So, whether you are a future healthcare provider, a curious student, or just a lover of how our bodies work, get comfortable, because by the end of this talk, you will not only know what cholinomimetic drugs are, but you will see exactly how they work, where they are used, and even how they can sometimes get us into a bit of trouble. Let us start right at the core. What are cholinomimetic drugs? At their heart, these are chemicals that either mimic acetylcholine by directly stimulating its targets, or boost the levels of this messenger by stopping its breakdown. Imagine acetylcholine as a voice calling out instructions, and cholinomimetic drugs are like an assistant, either helping shout the same message or making sure every word gets heard, loud and clear. Now, there are two main ways this can happen. First, we have direct-acting cholinomimetics. These drugs jump straight to the front of the action and activate what are called cholinesterase. That is, the specialized proteins that listen for acetylcholine's message. Think of these as custom-fit keys unlocking very specific doors inside your body. Within this group, we find choline esters, like acetylcholine itself, methylcholine, carbachol, and bethacol. These molecules are quite unique in their structure. They carry a permanent electric charge, a bit like how a battery keeps its positive and negative ends. Because of this, they have a hard time crossing into the brain, which is wrapped up tightly by the blood-brain barrier. Some of them, like methylcholine and bethacol, have a small tweak, a beta-methyl group attached. And what does this do? It makes them act less on one type of target, called nicotinic receptors, while also letting them stick around longer because they resist quick breakdown. The other branch of direct-acting drugs includes natural plant compounds, such as muscarine and pilocarpine, as well as synthetic relatives. These are usually tertiary amines, which is just a way of saying they are structured so they can slip through biological barriers like the skin or the lining of the gut, and even into the brain. Muscarine is a bit of an exception. Despite being a quaternary amine, it is less able to get across these barriers. But do not be fooled. It is still very potent and can be quite toxic. How do these direct-acting drugs work at the microscopic level? They bind to cholinesterase. These come in two main types: muscarinic and nicotinic receptors. Muscarinic receptors, with names like M1 to M5, are like tiny molecular switches that start second messenger cascades, fancy words for signaling pathways, inside the cell. Nicotinic receptors, found in nerves and muscles, act more like miniature channels that, when opened, let charged particles rush in and kick off whole bursts of activity. It is a beautifully orchestrated symphony, if you will. The other major pathway for cholinomimetic drugs is indirect. These are the cholinesterase inhibitors. Now, acetylcholine's message usually does not last long. There are hardworking enzymes, like acetylcholinesterase, whose whole job is to clear it out of the way after it has done its job. Indirect-acting drugs put the brakes on this process, preventing the cleanup and letting acetylcholine linger and continue sending its messages. There are a few flavors of these inhibitors. Some, like edrophonium, stick to the enzyme very briefly. Imagine trying to slow down a conveyor belt with a quick tap of your finger. Others, called carbamates, including neostigmine and physostigmine, form a more durable bond, slowing the enzyme for anywhere from 30 minutes to several hours. And then there are the organophosphates, such as malathion or the nerve agent serine, which cling on so tightly that the enzyme can stay blocked for days or even weeks. If a bond gets even stronger through a process called aging, the effect is locked in, and reversing it becomes nearly impossible. Where do these drugs end up in the body? Well, their journey depends a lot on their structure. The quaternary drugs, like some of the choline esters and neostigmine, have difficulty slipping through the skin or gut wall, and they especially struggle to enter the brain. In contrast, the tertiary compounds, and many organophosphates can absorb through your skin, lungs, digestive system, or eyes, and they can get into the nervous system. This can open possibilities for treating brain conditions, but it also explains their dangerous role in nerve gas poisoning. A fascinating tidbit about insecticide organophosphates. Some, like malathion, are actually harmless when we first encounter them. Only once our livers process them do they turn into their active, potent forms. Our bodies, in fact, can often detoxify malathion, sparing us from serious harm, but other insecticides like parathion are much more hazardous. The effects of cholinomimetic drugs play out across many organ systems. Let us walk through them, starting with the familiar rest and digest response. Picture your body on relaxation mode. In the eyes, these drugs cause the pupils to shrink, a process called miosis, and the muscles focus the lens more closely. This not only sharpens near vision, but also helps drain fluid from the eye, lowering the pressure inside, which is so important in glaucoma. In the heart and blood vessels, the story gets even more interesting. Some of these drugs coax the delicate lining of your blood vessels, the endothelium, to release a molecule called nitric oxide, which relaxes the vessel and lowers blood pressure. However, if the lining is damaged, perhaps by atherosclerosis, the effect flips, and instead you get constriction. In the heart, stimulating the right muscarinic receptor, called M2, slows the heart rate, decreases how forcefully the heart contracts, and slows conduction across the heart's electrical system. But reflexes and signals from the sympathetic system can modulate these responses, so it is always a balance. In the lungs, cholinomimetic drugs can cause the airways to narrow and glands to produce more mucus. This is why overactivity in this system can be a problem for people with asthma. In the gut and urinary tract, these drugs really get things moving, increasing salivation, boosting stomach and pancreatic secretions, speeding up digestion, relaxing the sphincters, and helping the bladder squeeze and empty. Sweat glands, interestingly enough, are activated only by muscarinic receptors in this case, not by the usual fight or flight pathways. That is why these drugs can cause notably profuse sweating. In the brain, the effects are diverse and fascinating. Muscarinic pathways are linked to learning and memory, as well as other processes like tremor control, sensation of pain, and appetite. Nicotinic pathways, on the other hand, can reward with a hit of dopamine, which partly explains the addictive power of nicotine. And they also shape how other messages are sent along. In the peripheral nervous system, activating nicotinic receptors across nerve clusters called ganglia causes both sympathetic and parasympathetic effects at first. But too much stimulation leads to shutdown, or what we call a depolarizing block. At the neuromuscular junction, the connection point between nerves and muscle fibers, cholinomimetics can actually help people with muscle weakness, like those who have myasthenia gravis. But a big overdose flips the effect. Instead of strength, you get muscle twitching, then paralysis. So where do doctors use these drugs in practice? Quite a few places, actually. In ophthalmology, drops or ointments of pilocarpine or similar drugs help reduce eye pressure in acute glaucoma attacks. For slow or paralyzed guts and bladders, medications like bethanechol or neostigmine get things moving again. Think of helping someone recover after surgery or correcting certain congenital conditions. For dry mouth, such as in Sjogren's syndrome or following radiation, pilocarpine or its more selective cousin cevimeline can stimulate much-needed saliva. In the diagnosis and treatment of myasthenia gravis, a disease of muscle weakness, short-acting agents like edrophonium help to sort out the diagnosis, while longer-acting drugs such as Pralidoxime provide ongoing symptom relief. Sometimes, if a patient is getting too much or too little, a rapid edrophonium test helps to fine-tune the dose. After surgery, when paralyzing muscle relaxants are used, neostigmine or edrophonium can wake up the muscles, reversing the block. In poisoning with drugs like atropine or certain antidepressants, which can dangerously block muscarinic receptors in the brain or body, physostigmine is the antidote of choice. It crosses into the brain and counteracts toxic effects. For Alzheimer's disease, where memory and cognition are lost, several cholinesterase inhibitors, such as donepezil and rivastigmine, are used to gently slow the decline of memory. In smoking cessation, controlled doses of nicotine or drugs like varenicline help break the grip of addiction by partially stimulating the reward pathways without delivering the full rush. Lastly, in situations of nerve gas exposure, a grim possibility in chemical warfare, Pralidoxime, together with emergency antidotes, provides some measure of protection. When it comes to toxicity, cholinomimetic drugs can pose serious hazards if misused. Too much can overstimulate muscarinic receptors, leading to a cluster of symptoms known by the handy acronym DUMBLES. That is, diarrhea, urination, meiosis, pupil constriction, bronchospasm, emesis, vomiting, lacrimation, tearing, and salivation. The life-saving treatment here is atropine, which blocks muscarinic effects. Nicotine poisoning presents a dramatic story as well. High acute doses first cause uncontrolled nervous system firing, resulting in seizures and dangerously high blood pressure, but soon lead to electrical burnout with muscle paralysis and breathing failure. Here, supportive care and symptom control are key, along with medications like benzodiazepines to calm seizures. Perhaps the most infamous poisonings are from cholinesterase inhibitors, such as those found in certain pesticides or chemical weapons. This can result in a frightening combination: pinpoint pupils, overflowing secretions, slowing of the heart, muscle twitching, seizures, and if not stopped, coma and death. Immediate management is critical. Clearing the airway and supporting breathing come first, followed by high doses of atropine until secretions dry up. And if it can be given in time, a compound called Pralidoxime that can restore enzyme function, but only before the inhibition is aged. For seizures, diazepam is used, and removing contaminated clothing and washing the skin is also essential. A few pearls to keep in mind. The reactions of blood vessels to cholinomimetic drugs depend on whether the lining is healthy. If it is not, the expected effect can reverse. Not all drugs can cross into the brain, so for central effects like poisoning, only the right structure will do. And when treating nerve agent poisoning, time is truly of the essence, because once the enzyme binding has aged, antidotes lose their power. Finally, let us run through some drug highlights. Befenacol works on the gut and bladder, but not the brain. Pilocarpine is a handy drop for eyes and mouth. Nicotine stimulates both nerves and muscles, but has its addiction and toxicity risks. Edrophonium acts quickly, helpful for diagnosis. Pyridostigmine stands as a first-line agent for myasthenia and for nerve agent protection. Neostigmine is a workhorse in reversing muscle weakness and post-operative muscle relaxation. Physostigmine can cross into the brain and is the go-to rescue for certain poisonings. Organophosphate insecticides have their dangers, but malathion is usually safer for humans because we can detoxify it. On the battlefield or in terror attacks, nerve agents like sarin or VX are some of the most dangerous, with effects lasting from minutes to days. As we come to a gentle close, let us remember, cholinomimetic drugs are powerful tools, acting on nearly every organ system, helping us treat disease, correct dangerous poisonings, and even shaping our approach to chemical threats. Yet with their power comes complexity, and above all, the need for careful, knowledgeable use. I hope you have gained a new appreciation for these remarkable agents, how they work, where they are used, and how we stay safe when using them. If you have questions, if something was unclear, or if you just want to share your own thoughts or experiences, I would absolutely love to hear from you. Please do not be shy. Let's chat about all things cholinomimetic in the comments below. Thank you so much for joining me today, and until next time, stay curious and keep asking questions. Bye for now.